Hello everyone, in this video we will be discussing about vasculitis topics one by one. I have made notes in such a way so that it will cover the previous topics and you can easily solve the marrow queuing of the vasculitis part. So let's start. Starting with large vessel vasculitis, temporal arteritis or giant cell arteritis. You can see these are all F's and don't get me wrong. So this is female more than male, more than 50 years age, and ESR there will be more than 50 ESR, and among clinical features there will be facial pain, fever, and firm and tender temporal arteries. So this is the catch points in the given clinical scenario. The most commonly affected branch, that is branch of the carotid artery. And in case of Takayasu arteritis, most commonly involved is subclavian artery. So apart from this, it can also lead to irreversible blindness due to anteroischemic optic neuropathy. It is also commonly asked question, and in the clinical scenario the question may be asked as polymyalgia rheumatica, and which is commonly associated vasculitis. Proximal muscle weakness and stiffness, but creatine kinase will be normal and ESR will be increased. And one of the very commonly asked question is what is the next step? Either treat with corticosteroid or biopsy. The answer will be treat with corticosteroid, then after you should do biopsy. And second topics among the large vessel vasculitis is Takayasu arteritis. It is also commonly known as pulseless disease, weak upper extremity pulse. Most commonly artery involves subclavian artery, and in histology there is granulomatous thickening and narrowing of the aortic arch and proximal gate vessels. Just read it, don't need to remember in such way. Commonly symptoms are very constitutional symptoms like night sweat, fever, ocular disturbance, neck pain, chest discomfort, joint pain, myalgia. And differentiating feature is that asymptotic BP in arms, limb claudication. This is the catch point in the question. And among criteria you should remember the 6 points. Age of just remember the criteria, not the definition. The first criteria is age of the patient at disease onset is should be less than 40 years. Claudication of extremity, decrease brachial artery pulse difference more than 10 mm Hg, brute over subclavian artery or aorta, and aortogram abnormality such as narrowing, occlusion, this set. And ESR obviously will be increased, and corticosteroid treatment. So catch point is the age of the patient less than 40, asymptotic BP, limb claudication, decreased brachial artery pressure, brute, and arteriogram. This you have to remember to make the diagnosis and answer the question. Now come to the medium vessel vasculitis, Barger or Barger, polyarteritis nodosa, Saki. In the Barger disease, it is also known as thromboangiitis obliterans. So like claudication in Takayasu, here you also got claudication. Chronic lower limb ischemia, there is 2, Barger and atherosclerosis. So in Barger you have to remember that it not only involve artery but it also involve veins and nerves. This is the one thing I made mistake many times. And it is small to medium size vessel, and atherosclerosis is large size vessel. Yes, but you can remember easily. Third or fourth decade, associated smoking, male more than female, lower limb more than upper limb, both are same. Here it is fifth decade, male equal to female, lower limb more than upper limb, and artery more commonly involved, and as I said large vessel. And Barger distal to proximal spread, here proximal to distal spread. That's it. And extra point, internal correlation I have said before. And Barger may lead to gangrene, autoimputation disease, superficial nodular phlebitis, and Raynaud phenomenon is also present. This is the catch points in the clinical scenario of the MCQ. And for treatment part, you have to see the surgery note, maybe marrow or whatever institute you read. Now come to polyarteritis nodosa part. It is also medium sized vessel and commonly involve middle aged males. Constellation syndrome are same, fever, weight loss, malaise, headache. Don't have to remember that much. There is 3 no and 3 yes. No to pulmonary, no to lung involved. There is one mnemonic such PAN, polyarteritis nodosa, and pulmonary never. There means no lung involved, no diffuse alveolar hemorrhage. There is one no. No glomerulonephritis. Even if kidney is involved, but there is no glomerulonephritis. No ANCA negative. And among 3 yes, one is hepatitis B yes, that is hepatitis B seropositive. One is hypergammaglobulinemia, and one is fibrinoid necrosis. You have to remember the 3 point. 3 yes. And among the clinical features, you don't have to remember the table, you just remember the specific points. In renal, there is renal failure, hypertension, and in imaging there is renal microaneurysm, spasm on atriogram, that is called sting of pulse appearance. That means in imaging you will get microaneurysm and spasm. And peripheral nervous system, there is mononeuritis multiplex, that is random patch involved of the sensory and motor nerves, asymmetric appearance. And GIT, there you will get abdominal pain, bleeding, hematogagia or melena. And seeing, there is livedo reticularitis. This is also image based question. Can be asked which vasculitis is associated with livedo reticularitis, PAN. And cardiac generation, CNS. You don't remember the whole table, just remember the important points. Now let's start with Kawasaki disease. It is also called as mucocutaneous lymph node syndrome. In question, you may be given the option mucocutaneous lymph node syndrome, but no Kawasaki disease will be given there. So remember the name. It is seen in mainly in children less than 4 years of age, and never seen in adults. It may develop, patient may develop coronary aneurysm, thrombosis or rupture, which can cause death. And there is a mnemonic called cream. There is also crash burn, something like that. I don't remember that. The cream is the easier one. The patient will be having fever for more than 5 days, and along with 4 of the out of 5 features. C stands for conjunctivitis, which is non-exudative, bilateral, and sparing the limbus. Conjunctive part is bilateral, but the adenopathy part is unilateral. R stands for rash, which is polymorphic, non-vesicular, and discomating. E stands for edema and erythema of the hand or feet. A stands for adenopathy, which is cervical, unilateral, with one node more than 1.5 cm in size. And M stands for mucosal involvement, which is erythema or fissering or crusting, which is commonly known as strawberry tongue, also oral mucositis. There are another 2 strawberries, strawberry nose, rhinosporidiosis, and strawberry gallbladder, cholesterolosis. And Kawasaki associated with thrombocytosis. This is also a commonly asked question. And treatment is IV immunoglobulin or aspirin. Steroid is given later. So you should mark IV immunoglobulin and aspirin part. Now coming to the small vessel vasculitis. First we will discuss the immunocomplex mediated part, then we will discuss the ANCA parts, ANCA disease. So among the immunocomplex mediated, what is BACET? So there is a criteria to remember that. Patient should be having recurrent oral ulceration, aphthous or herpetiform, which is at least 3 times in 1 year. That means at least more than equal to 3 times in 12 months. And the ulcer as usual will be painful but not scarring. Along with this, patient must have 2 of the following 4 criteria. One is recurrent genital ulcer, which will be painful or scarring. Eye lesion, uveitis, which will be scarring. And skin lesion, erythema nodosum, and positive pathology test. So patient will be oral ulceration along with 2 of the 4 features. So that will call BACET disease. And on the commonly asked question is conforming test is pathology test, which is type 4 sensitivity reaction. And in clinical scenario you can get the question such as there is Turkish people or Eastern Mediterranean descent people came with the OPD with the following feature. So you should suspect the BACET disease. And the flares lasts 1 to 4 weeks, can be precipitated by HSV or parvovirus. Just remember the name. And commonly asked is HLA association. You can search in YouTube HL Association Mnemonic by Dr. Nikita. You should watch the video and make note of the video so that you can easily remember that the HLA part on other mnemonics. So base set is associated with HLA B5 or B51, and there is increased risk of thrombosis and neuro features such as demyelination in CNS or very high IL-6 in CSF. Just remember the things. The main thing is this part. And after base set there is HSP, which is also called as immunoglobulin A vasculitis. Vasculitis secondary to IgA immunocomplex deposition, often follows upper respiratory tract infection and associated with IgA nephropathy. Clinical triad of HSP: H stands for hinge pain, that is arthalgia. S stands for stomach pain, that is abdominal pain associated with intussusception or bowel ischemia, may lead to nausea, vomiting, diarrhea, blood in stool. And P stands for palpable purpura on buttock and legs, but the platelet count will be normal. This is also commonly asked. So remember the mnemonic HSP. IgA deposition, skin biopsy, there is all IgA. It is the most common childhood systemic vasculitis worldwide. And treatment part is supportive care, corticosteroid, immunosuppressant, that's it. And next is mixed cryoglobulinemia. If you remember the HSP part, you can easily remember the mixed cryoglobulinemia part. There is all C, often associated with hepatitis C virus, cryoglobuline, all C. But the vasculitis is not due to IgA. Here it is due to IgM and IgG. That's it. And there is also type of HWP. There is HSP, and instead of S there is weakness. It's the same, hinge pain and palpable purpura. That's it. And may involve peripheral neuropathy and renal disease. Okay. So you have to remember the three things: hepatitis C virus, cold immunoglobulin, also C, IgG, IgM, and triad of HWP. There is HSP, HWP. Now coming to the cutaneous small vessel vasculitis, the most commonly involved is post-capillary venules. It is also commonly asked. It is also, as you know, immunocomplex mediated and occurs 7 days after certain medication, infection, palpable purpura, no visual embolus. This all common as above. You don't have to remember this part. Just remember the most common involved part and which of the immunocomplex mediated or not. That's it. Now coming to the ANCA part, as you have seen in previous video, we will discussing with the Wegener granulomatosis. So there is triad of three things: upper respiratory tract, lower respiratory tract, and renal. Among the upper respiratory tract there is perforation of the nasal septum, chronic sinusitis, otitis media, mastocytosis. That's it. And lower respiratory tract there is hemoptysis, cough, dyspnea, and in renal part there is hematuria, red cell cast. And histologic triad there is three: necrotizing granuloma in upper airway and lung, necrotizing glomerulonephritis, and focal necrotizing vasculitis. Just remember the names, but you have to always remember the three clinical feature, because we will discuss microscopic polyneurosis almost same. And CXR there in chest X-ray there will be large neural density, also skin, musculoskeletal involvement there, ocular GI genes involvement there, and there is corticosteroid along with rituximab or cyclophosphamide as treatment. So here we got triad of upper respiratory tract, lower respiratory tract, and renal. If we omit the upper respiratory tract, then we got the microscopic polyangiitis, and also we have to omit the granuloma part because there is no granuloma involvement. So microscopic polyangiitis you don't have to mark up, you just remember the similar to granulomatosis polyangiitis, that is Wegener granulomatosis, but without any nasopharyngeal involvement. So necrotizing vasculitis will involve the lung, that means lower respiratory tract, kidney, and skin. Here also skin was involved. And there is no granuloma. Instead of granuloma there will be fibrinoid necrosis and leukocytoclastic vasculitis. Just remember the two. And treatment corticosteroid, cyclophosphamide, don't have to remember. And Church-Strauss disease, also called as eosinophilic granulomatosis with polyangiitis. Here in lesion there is subcutaneous nodule, palpable purpura as above. There will be eosinophilia, that means asthma, sinusitis, IgE level, and asymmetric mononeuritis multiplex is some type of peripheral neuropathy happening in at least two nerves. Patient may have reached of foot of, that's it. And there will be granulomatosis necrotizing vasculitis with eosinophilia. Can involve heart, GI, kidney. Not that important. Just remember the post-immune glomerulonephritis. In the triad of skin, eosinophilia, asymptomatic, mononucleotic multiplex, it is important. So we have almost complete all the topics which are asked in previous years from vasculitis part. You can easily solve the marrow Q-bank now. Two things you have to remember: most common form of vasculitis associated with connective tissue disorder, small vessel venulitis, not vasculitis, venulitis here, and the presence of cutaneous vasculitis, glomerulonephritis, and peripheral neuropathy suggestive of it is small vessel vasculitis. It is also previously asked many times. Cutaneous vasculitis, glomerulonephritis, and peripheral neuropathy, small vessel vasculitis. Next step is ANCA, investigation for ANCA. See you in next video with rheumatoid arthritis.